Perfect. Thank you very much, Jess. Thank you everyone for joining us this afternoon. I hope you'll find this talk interesting. Yes, my name's Ramesh Nadarajah. I'm one of the cardiology registrars based at Leeds Teaching Hospitals, and I'm a visiting research fellow at the university. And actually, my PhD was in the prediction, detection, and diagnosis of atrial fibrillation. So hopefully, I'll be able to give you some insights into current practice, current guidelines, but also some of the interesting sort of research that's been going on in this area, but also the research and the innovation we're doing in the local area around this. So I hope you will find it interesting. I'm going to assume a little bit of knowledge about atrial fibrillation. So we all know that it's an irregular heart rhythm related to irregular absence of fibrillations in the left atrium particularly, and it's the most common sustained abnormal heart rhythm in the world, with about 36 million people worldwide and over 1.4 million people diagnosed in the UK. And of course, an important component of atrial fibrillation is the association with stroke risk, so a quintupled risk of stroke. But we also know that we have the ability to significantly reduce this risk of stroke by using oral anticoagulant drugs, which leads to this issue about detecting, but also protecting and perfecting our treatment of atrial fibrillation. This is an increasing problem in the UK. So we did some research which showed that if you look over the last 20 years, the number of new cases of atrial fibrillation has increased by 72%. That's the number of new cases diagnosed each year. So that's a remarkable increase. And actually now we have more new cases of atrial fibrillation diagnosed in the NHS each year than the four most common causes of cancer combined. So it's a big public health issue. But we also know that even though we're detecting a lot more cases than we did before, there's a significant gap between how many cases are detected and how many are estimated to be undiagnosed. So we estimate currently there's about 300,000 people in the UK living with atrial fibrillation for whom have not received diagnosis yet. And these people are at increased risk of stroke. So we know that about 15 to 25% of strokes per year occur in the context of undiagnosed or untreated atrial fibrillation, which is a large burden of individuals in the UK. And accordingly, the NHS long-term plan, one of the cardiovascular priority areas was early detection of atrial fibrillation, and hence why we're talking about it today. Of course, it is worth also remembering that atrial fibrillation uh, is associated with things beyond stroke. We know that individuals with atrial fibrillation, as you can see in this kind of panel on the left-hand side, those individuals compared to people without atrial fibrillation are at increased risk of a large number of different adverse outcomes, including death, ischemic heart disease, kidney disease, and heart failure, specifically heart failure, in addition to stroke. And we actually know that atrial fibrillation often occurs in people who've got other medical problems, and actually within a year of diagnosis, remarkably, almost a fifth of people die. So not necessarily because of the atrial fibrillation or because of a stroke, but because they're unwell in the context of the atrial fibrillation becoming manifest. We do have some approaches to detect atrial fibrillation at the moment. So NHS England, as part of the Improvement and Innovation Fund, recommend opportunistic pulse palpation alongside blood pressure checks during community care. But we also know, as I'll come on to a bit later in the talk, that randomized control trials have suggested that actually doing pulse palpation doesn't actually increase detection rates of atrial fibrillation compared to routine care. We also know that when people attend the NHS health checks, that there's opportunistic pulse palpation at those events. But we also know that only about 44% of those who are eligible to go for an NHS health check attend, and there's massive variation by geography and socioeconomic class. There is also the option to systematically investigate people. So let's say for everyone who's older than a certain age, that we provide them with some sort of AF detection device, and we'll come on to that again a bit later. And we do know this actually does increase detection rates of atrial fibrillation, but there are some issues with this approach as well. We know that the yields for such an intensive process by actually giving people with the monitors or sending them out with the monitors is still pretty low. And we also know that there are certain people who are less frequently targeted for these approaches, and there are certain people, especially younger people from more socioeconomically deprived backgrounds, who may be at risk of atrial fibrillation earlier, but may be missed by such a systematic approach based on age. So certainly we know that early identification of AF may be able to prevent stroke and hospitalisation and is an NHS long-term plan priority. But we also believe that the current approach we use to detect atrial fibrillation early in the community are, relatively speaking, unsuccessful. So what can we do? Well, there are lots and lots of different devices that we can use to detect atrial fibrillation. Um, and some of these are apps on your phone, like the ones you can see on the left-hand side of this panel. Some of them relate to wearables, so things that patients wear during their daily lives, whether it be an Apple Watch or a Fitbit. Um, and there's also certain specific medical devices that people can be given. So you can have handheld devices, which patients need to place their fingers on, and they record a 30-second lead ECG. Your smartwatch can also do that if it's triggered by a certain number of irregular beats to take an ECG. And then you have more intensive approaches, which involve longer periods of monitoring, where you have patches which you can wear for for a few weeks or up to a month or so, which record the ECG continuously during that period. Or you have more kind of classical methods, such as the Holter monitoring, where you have numbers of leads. As you can see, you have a range of devices which are either or a range of technologies which are either within devices that people already have or specific medical device which we can use. And so you have this opportunity that patients might come to you and say, my app or my watch has told me I've got an irregular heartbeat, or you can actively go out and provide medical devices for individuals who are at high risk of atrial fibrillation. It's worth just briefly noticing on this panel that on the right-hand side of the panel, you have the ECG-based AF detection devices, and these are devices that are truly diagnostic of atrial fibrillation, because at the moment, to diagnose atrial fibrillation, you need to find irregular RR intervals on an ECG without P-wave activity. Whereas the PPG-based devices on the left-hand side are not truly diagnostic. They are very much suggestive of atrial fibrillation, but they're not diagnostic because they're not providing you an ECG, but they're just checking pulse variation. So they can pick up ectopics without being diagnostic of atrial fibrillation. So if you have somebody who comes to you with irregular heart rhythm based on a PPG device, it's worth making sure they actually get an ECG device or a 12-lead ECG for diagnostic purposes. So if we're talking about that we need to detect people with atrial fibrillation, there's a big gap, people are having strokes, should we be screening people? And in this context, there is some variation between international and national guidelines. If you look at the European Society of Cardiology, they recommend that everyone over the age of 65 gets an opportunistic screening for atrial fibrillation on each healthcare contact by pulse palpation or with an ECG. And they actually recommend for those who are older or at high risk of stroke, but that's not clearly defined, what that CHA2DS2-VASc score would be. They recommend some sort of systematic approach, i.e. giving them an ECG detection device. By contrast, the US Preventative Services Task Force in 2022 felt that there was current evidence to actually recommend atrial fibrillation screening, and the UK National Screening Committee, admittedly a number of years ago now in 2019, when they last looked at the issue in detail, did not recommend atrial fibrillation screening at that point. And I thought now we just jump into a bit of the evidence around atrial fibrillation screening, just to understand why there might be some divergence in these guidelines. So the first question, I guess, when you're talking about whether you're going to screen someone or try and case find atrial fibrillation is, are you effective at actually detecting new atrial fibrillation? So there is opportunistic screening, which involves when an individual attends to a healthcare setting, whether we check their pulse or do an ECG. And though this was found to be effective about 20 years ago or so, the most recent large randomized controlled trials, the D2AF trial and the VITAL AF trial, both showed in thousands and thousands of patients that actually in the primary care setting, if we employ this approach compared to routine care, we don't actually increase detection rates of atrial fibrillation. By contrast, if you look at approaches that are systematic, so that means finding a substrate of the population and providing them an AF detection ECG device for a period of time, you do increase detection rates compared to routine care. And the table at the bottom of this slide shows a number of the trials that have been done in this area. It shows the populations that they've been targeted at, which has generally been older populations and people with elevated CHA2DS2-VASc scores, so elevated stroke risk. And it shows that they've predominantly used either serial rhythm monitoring devices. So this means devices like handheld devices that you can use a few times a day for a few weeks, or a continuous monitoring device, so a patch that you can wear for a few weeks. And on the right-hand side, you can see that you do get increased detection. So I think routine care, we're probably going to pick about 1.1 or 1.2% of atrial fibrillation in the control arms of these populations. Generally speaking, the detection rates are higher when you do these more systematic approaches. It is worth noting at the bottom there, you can see the loop study, which had a remarkably high detection rate of atrial fibrillation, but that involved actually implanting a loop recorder. And obviously this approach is not going to be scalable in the community at scale, and patients are probably going to be less keen to have an implanted device rather than have a non-invasive device. So after you've decided whether you can detect atrial fibrillation more effectively with screening, which we've shown we can do with either serial or continuous rhythm monitoring devices, does this actually make a difference to outcomes? So if you look at the stroke stop population, this had, as you can see at the bottom of these panels, about 13,000 people or 14,000 people in the control arms and the people who were invited to screening arm. What you see on the left-hand side is a primary outcome of a composite of ischemic or hemorrhagic stroke, systemic embolism, or major bleeding into hospitalization, or all-cause death, I believe, as well. And as you can see, if you look at the people who were invited versus the people who weren't invited to screening, there's a small difference in terms of improvement of outcome, very small difference. That's a sort of funny composite outcome. If you look at the panel in the middle, which is the secondary endpoint of a stroke, ischemic stroke, if you look at the people who were invited for screening versus the people who weren't invited for screening, you can see there's visually a slight improvement, though the confidence interval does actually cross 1, so it's not statistically significant. And then if you look interestingly on the panel on the right-hand side, this panel C, if you look at, so these are the red arm is the people who were invited, and then the dark blue arm is the people who were controls, and the light blue arm is the people who did not participate, so who were invited for screening but did not participate. And what you can see there is that people who are invited to screen, and the outcome is ischemic stroke. So what you can look at is that people who are invited to screening and people who take part in screening get a significant improvement in reduction of stroke risk compared to those who are not invited to screening. And furthermore, the people who are invited to screening who do not take part are actually the ones who are at highest risk of stroke. So therefore, theoretically, the people who have the most to gain from this. So this suggests to me that actually screening for atrial fibrillation in terms of actually the people who undergo the test, that does eventually to a benefit of stroke prevention, but you are limited by the uptake of screening. So if as you can see here, if you look at the numbers at the bottom there, of the people who were invited, only half of them actually participated in screening. And even amongst those people who participated in screening, the detection rate was only 3%. So what we're talking about here is with a detection rate of 3%, which is a very low yield really of atrial fibrillation, you're still getting a significant benefit in terms of stroke prevention. But what you need to do is try to improve that stroke detection and try to improve the number of people who actually participate, because the people who don't participate are the people you definitely need to get to. And there are certain things we can look at there in terms of the people who don't participate. This is the data from the loop study. So the loop study was the one that used an implantable loop recorder, so quite an invasive approach to AF detection. And this is a much smaller study. As you can see, the numbers at the bottom of these panels, they had about 1,500 people actually underwent the loop recorder, and about 4,500 people were in the control arm. And what you can see here is that if you look at over the course of 5 to 6 years, the people who had AF screening using the implantable loop recorder, they had a high detection rate, so about 31%. And there is an evidence of a divergence in the outcome of stroke in panel A over the course of the follow-up. But it looks like this, and so the hazard ratio is quite impressive at 0.8. But it looks like this trial is probably a little bit underpowered because they have very wide confidence intervals and therefore didn't reach statistical significance. And then if you look at all-cause death in the bottom panel, so these are individuals who had a high detection rate of atrial fibrillation, and yet there's really no difference in prevention of death by detecting atrial fibrillation. Whereas there seems to be probably a difference in detection of stroke. That kind of probably confirms what we know, which is we're detecting atrial fibrillation to prevent a stroke and all the important morbidity and disability implications of that, and significant cost effectiveness of that, and healthcare expenditure. But we're not necessarily going to be preventing death from detecting atrial fibrillation, because people can die from a number of different outcomes. Certainly, as you could tell from the stroke stop study, which had a composite outcome, including bleeding, and did also look at a secondary endpoint, we didn't find evidence from these two large trials that there was any evidence of significant harm from atrial fibrillation screening, but the benefit seemed was not well proven. I think this relates to a number of things. One is that they're using different types of devices. So one, the stroke study was using just a handheld monitor a couple of times a day for a couple of weeks, whereas the loop study was implanted people with loop recorders for which was left in for years on end. So these are completely different ends of the spectrum of atrial fibrillation screening. And so it's not surprising you get slightly divergent results, and probably the optimum approach is somewhere in the middle. There's also the question that if you are continuously monitoring for atrial fibrillation, so you're monitoring someone for 3 years for atrial fibrillation, you pick up more than 6 minutes of atrial fibrillation in that period, is that the same burden of atrial fibrillation as if you give somebody a handheld device and you ask them to check for 30 seconds for atrial fibrillation twice a day? It probably isn't. If you're picking up atrial fibrillation on a handheld device that you're using twice a day, you're probably talking about a greater burden of atrial fibrillation than just 6 minutes. And what we do know, that if we have atrial high rate episodes picked up by pacemakers, so this is kind of incidentally picked up in people who had devices in situ, and you treat these high rate episodes, which are sort of subclinical atrial fibrillation, with an anticoagulant, you don't actually reduce adverse outcomes, but you do increase bleeding. So that's probably not atrial fibrillation that's worth treating. Whereas we do know from the Artesia study that if you've got slightly longer periods of atrial fibrillation between 6 minutes and 24 hours that's picked up on a continuous monitor, and you treat it with apixaban or you treat it with aspirin, that you do reduce the risk of stroke or systemic embolism with an anticoagulant compared to aspirin, but you do increase the risk of bleeding. So we still need to quite work out exactly what the burden of atrial fibrillation and the type of device that should be used to optimally screen for atrial fibrillation to definitely improve outcomes and balance that against the obvious increased risk of bleeding you get from giving someone an anticoagulant. There's also some important points about the practicalities of screening and early detection of atrial fibrillation. As we saw in the stroke stop study, the people who were invited and took part got a benefit, but the people who were invited and didn't take part almost did worse than the control population. And this is because the people who don't participate tend to be people from lower educational status, older people, and more comorbid people, and people who are less wealthy. And so if we are going to try and detect people with atrial fibrillation, the approach we take needs to try and target these individuals who have hitherto not taken part in these more systematic and outreaching approaches. We do also know that if we're not going to be able to implant people in the community at scale with implantable loop recorders, this probably won't be an acceptable approach for patients. But we also know that if we use non-invasive approaches at the moment, such as continuous monitor devices or handheld devices, we're only picking up about 3 to 4% atrial fibrillation, or 3 to 4 atrial fibrillation cases for every 100 people we screen, and this severely limits the cost effectiveness approach. So really, as we go forward, we need to try and improve the amount of yield of atrial fibrillation we're going to get in a population where we provide them a monitoring device. We need to improve the uptake of screening, especially from certain population groups. And if we do both these things, we may get some clinical benefit from that. So this leads on to some of the work I did during my PhD, which looked at how we can identify the people who are at high risk for developing atrial fibrillation. And if we could find those people, then we have the people who would be more effective for us to target with our AF detection devices. And my work looked at particularly using data that's in our primary care electronic health records to do this, because we know that 98% of the UK population are covered by the primary care records. So if we use this data source to identify people at high risk, we can scale this across the country. And so this can be useful because it's embedded within our structures we already use. It can automatically calculate it from the data we have in our electronic health records, and we can minimize extra costs. We don't need to do extra tests to identify who's at high risk because we've already got the data available to us routinely. Um, Obviously, this has been work that people have looked at, and so we did look at systematically about what sort of um, tools or risk scores have been used to try and predict people at risk of atrial fibrillation. So as you can look on the left-hand side, you've got a few scores that have been tested at scale. So the CHAD score and the CHADS-VAS score, that many of you will know, are actually originally developed to predict stroke risk in individuals with atrial fibrillation. But because many of these factors, things like hypertension, age, and diabetes, also increase your risk of atrial fibrillation, we do find they're mildly predictive of atrial fibrillation risk. But these numbers of discrimination points of 0.67 are not particularly good. We're usually looking for numbers more around 0.75 and 0.8 to be useful. The CHEST score, which was developed to predict atrial fibrillation, was developed actually in China and Korea. Is relatively good at predicting atrial fibrillation risk, but this is in these cohorts were all in China and Korea, so that might not be relevant to the UK population. And similarly, the Hatch score was actually developed to predict risk of progression from paroxysmal um, persistent atrial fibrillation, and again is not that predictive, and again has predominantly been tested in populations in Korea, China, and Japan. So it's maybe less relevant to the UK population. Also, all of these models have really been tested to predict who's at risk of atrial fibrillation over the next 10 years. But that's less useful when we're trying to decide who should we provide a detection device to now to identify atrial fibrillation. And some of the more the newer and AF-specific algorithms that have been created, things like ChargeAF and Pulse AI, are pretty predictive of atrial fibrillation risk, but then they're pretty difficult to implement at scale in the community, especially through primary care records, because the type of data they require is not routinely coded. And so you can only apply it to between 17 and 35% of the population. And when we're talking about trying to reach out and be able to detect across the population, if you can only detect it to a minority of the population, we're not being fair to a great deal of the population, especially those who interact with healthcare services less, and therefore might have less information in their primary care records. And also, we don't know yet how these models perform for men and women and in different ethnic groups, which of course is important when we're considering who we're going implementing these sort of models to identify people for atrial fibrillation screening in real life. We did actually, as part of our research work, we convened a scientific advisory board, which involved some of our National Cardiovascular Disease Prevention Lead, some of the EHR providers, and some of our representatives from NICE, patient-facing groups, and our PPI group. And what we were looking at is how should we try and identify people who are at risk of atrial fibrillation. Uh, our feedback from our primary care professionals on our board and our cardiology professionals and the patients was that they wanted something in primary care that could help them identify people who are at risk of atrial fibrillation. And they also said that it must be implementable within the current data we hold within primary care electronic health records. And they didn't want something that was going to be changing all the time. They wanted a fixed algorithm that could be implemented and could be implemented again and again to identify the people who were at risk of atrial fibrillation, but also something that should be implementable for everyone and shouldn't be affected by if someone's had a blood pressure taken last year or not. Accordingly, we did some work where we used machine learning, so ran a Forrester type of machine learning algorithm, and we used over 2 million records in the UK of primary care records, and we trained this machine learning in about 80% of the population, and then tested it in the other 400,000 individuals. And what we were doing was developing a score that takes data that's routinely collected: age, sex, ethnicity, and diagnoses, to predict a score for each individual of their risk of atrial fibrillation, and then defining people as higher and lower risk. We then tested this model, the FIND-AF model, against some of the models I already discussed, so CHADS-VASc and the CHEST score, and we checked for outcomes for atrial fibrillation, a number of other things, and applicability within the dataset. this is all a bit scientific, but what we were looking at was how well we can predict atrial fibrillation. So these are curves that look at the kind of the balance of sensitivity and specificity on this diagnostic tool, and you really want your curve to be as close to the top left-hand corner as possible. As you can see, the FIND-F curve was the best of these different models that we tested. And this is borne out in this figure, which sort of describes the ability of a model to predict correctly between two random individuals. So the FIND-F model, which we developed, was better than the CHAS-FAS model and the CHESS model. And then we did some really important things about checking, actually, just because it's got really excellent predictive performance, greater than 0.8, so greater than 80% of the time, right between the two individuals. How good does it perform in men and women and in different ethnic groups? Because if we're going to implement this, we want to make sure we're being fair in how we implement it. And we found that it was really equally accurate in men and women, but also pretty robust in different ethnic groups and in those who maybe interacted less with healthcare services and so therefore didn't have an ethnicity recorded. So this suggests that actually it's an accurate algorithm in the UK, and that actually if we implemented it, it would be equally accurate whether we were implementing it in men, women, or in different ethnic groups. But we're also really interested to know whether, if we've got this algorithm, can we actually apply it in primary care records? So across these 2 million people, we actually found that we could apply it to every single record in that data set, which is really important, given that many other algorithms you can only implement in a very small proportion because they require quite complex data, or for observations and laboratory measures which might not have been done in the community. And then when we did some modelling around, well, if we implemented it, would this improve things? This point being the no improvement. As you can see, it's improving across all potential applications. So overall, we found that it was accurate. We found that it was scalable in the current data that we have, and that an important point which I didn't mention was it was specifically trained to predict the risk of atrial fibrillation over the next 6 months. So we're not talking about predicting atrial fibrillation risk in 10 years' time, which is less relevant to who should I give a detection device or who should I bring in for an ECG now. It was specifically developed to predict risk of atrial fibrillation within the next 6 months. So these are people who we think are right on the cusp of developing atrial fibrillation, or of people who are already manifest atrial fibrillation but who have yet to be diagnosed. And we know that it's robust in its performance across different ethnic groups and different sexes. We were also interested, though, by, if you're at risk of atrial fibrillation, are you also at risk of stroke? So if we're going to try and use this cohort to detect atrial fibrillation in, are we definitely picking the people who it's beneficial for, i.e. they're at high stroke risk, so we're definitely going to give them an anticoagulant to reduce their risk of stroke? And what we found was that individuals at risk of atrial fibrillation in the short term, so just this small segment at the front of here in the first 6 months, just because they're at risk of atrial fibrillation in the first 6 months, they're also at risk of atrial fibrillation over the next 10 years. And this is very different to the people who are considered lower risk, who really are very low risk of atrial fibrillation over the next 10 years as well. But not only are they at risk of atrial fibrillation, but they're also at risk of stroke over the next 10 years as well. So this is a cohort of individuals who are at risk of atrial fibrillation and at risk of stroke. So if we do find AF in these individuals, and if we do identify them, we should be definitely trying to prevent their stroke risk. So we know we can apply this algorithm in national primary care electronic health record data, and we can actually predict short-term risk of atrial fibrillation. And this actually portends longer-term risk of atrial fibrillation and longer-term risk of stroke. So we may be worthwhile targeting this subpopulation for diagnostics so we can be more efficient in our diagnostics of atrial fibrillation and detect atrial fibrillation early before they have a stroke. But of course, this always needs prospective testing, because this was testing done in 2 million records from routine care. So what we're now doing across the Yorkshire and Humber area, and we've done this with the Academic Health Science Network, is we're doing a prospective clinical validation. So we know that we can identify people at higher risk of undiagnosed atrial fibrillation just from the data we already have in primary care. And now we also need to look at how we can improve access to diagnostics for these individuals. So we want to leverage this novel machine learning technology within our primary care records to provide us personalised prediction of atrial fibrillation risk. And we want to provide a pathway that's patient-centred and overcome inequities in access to care so that we can prevent later stroke by detecting atrial fibrillation early. So some of the work we've done on this using in the FIND-AF study has been funded by the British Heart Foundation and Leeds Hospital Charity. So we are taking individuals who are who are definitely eligible for anticoagulation, so with an elevated CHA2DS2-VASc score, but without atrial fibrillation and not already on a long-term anticoagulant and not on the palliative care register, so people where AF detection will make a difference. We're taking them and we're risk stratifying them by their FIND-AF risk score. And we're trying to do quite an inclusive pathway. So we're doing text invite and letter invite to individuals to participate in this pathway. And if they consent to participate, we're actually sending an ECG monitoring device to their home. So they receive the invite, they can consent to take part, and they can undergo their ECG monitoring without ever having to leave their home. And we're trying really hard to reach people rather than put up barriers that might make people not want to take part in an AF detection pathway. And if we find that we've got AF diagnosed by this pathway, we provide that to the primary care healthcare professionals who can then do their usual care based on their usual treatment, usual guideline directed care. But if we pick up other abnormal rhythms, then we manage that in secondary care. And importantly, we are including people in this study at both high risk and low risk, so we can identify the difference in AF yield we get by providing AF diagnostic devices to individuals across the FIND-AF risk strata to identify the best kind of threshold at which we'd implement this in routine practice. In this prospective clinical validation, we're doing this across 1,955 people in the West and South Yorkshire area, and I think we've started in 17 practices across West and South Yorkshire, but also extending that further. And our primary outcome is we're trying to find out in this population who are already elevated stroke risk, so men with a CHA2DS2-VASc score of greater than 2, or women with a CHA2DS2-VASc score of greater than 3, or greater than or equal to 3, we're trying to find out the incremental benefit of using this risk prediction algorithm. So we're checking the diagnosis of AF during rhythm monitoring in the higher risk people versus lower risk people according to the machine learning algorithm FIND-AF. We're also looking at the kind of specific statistical performance metrics, and of the people who we do diagnose with atrial fibrillation, how many of them do we then treat with anticoagulation? Because the only point of detecting atrial fibrillation in current guidelines would be to get them on oral anticoagulation to prevent their future stroke. But we're also characterising higher risk individuals who take part in this study with echocardiography and some basic investigations to understand, are there markers for these higher risk individuals who don't actually have AF when we diagnose them, that we find, oh, they've got certain things that make them very high risk. Maybe they weren't picked up now, but they're very likely to get it in the next few years, in which case we can maybe do some things to try to prevent their atrial fibrillation. Can we control their blood pressure better? Can we control their heart failure better? Can we get them to do a bit more exercise? All these sort of things. It's also worth noting that this has all been done because actually we can use FIND-AF in routine care. We've gone through the appropriate regulatory approvals for this medical, effectively what's a software medical device to be used in routine practice. So it's a UKCA certified device. It's gone through all the other digital technology assessment criteria and DCB clinical safety regulatory criteria to be used in the NHS. And to inform this work since inception and to take it further forward, we've got a really important group of national and regional stakeholders. So we have our national supportive both charities, foundations, and important societies, and of course across our region we've been interacting with our cardiac network, integrated stroke delivery network, the clinical information officers, especially the innovation board and the academic health science network it was previously referred to. But we've also got our primary care partners who are taking part in our Find AF study, and we're always looking for more people who want to partake and are interested in the area of detection and diagnosis of atrial fibrillation in the community. And we're, of course, grateful to our scientific advisory board and our PPI group, who constantly keep us on track to make sure that we're doing things that will benefit patients in the future. So in summary, there are opportunities to detect atrial fibrillation early before adverse events, and there is data to suggest that early detection of atrial fibrillation can prevent adverse outcomes, and there's no evidence yet that it's harmful, and it's certainly an NHS long-term priority. We do know from our own research work that primary care data can be used to identify people at higher risk of both atrial fibrillation and stroke. And so we should really use this data source to identify people at high risk who are the most fruitful to give diagnostic devices to, and also the people who stand the most to benefit from prevention of stroke risk. The Find AF study is currently being conducted in the Yorkshire and Humber area to test risk-guided AF case finding effectively, AF screening. And of course, if you're interested in taking part or joining or informing us as we go forward to try to improve AF detection diagnosis in the community, we're always really willing to work with people or just take advice from people. So thanks very much for listening to me today. More than happy to take any questions anyone might have. I know I've raced through that because we've only got 40 minutes or so, but I just want to more than happy to answer any questions or take any questions offline as well.
Thank you so much for that, Dr. Nadarajah. We do have one question. It was more about handheld ECGs. We have the device, but not sure how to record and how to interpret it.
Right, yep. So I'll go back to that slide on different devices. So it kind of depends on what device you have. So there's lots of different handheld devices. There's Zenicor devices, live core devices, My Diagnostics. I presume they're talking about a handheld device rather than an Apple Watch. With a handheld device, generally speaking, when you place the fingers on the recorders, a recording is sent to a cloud for analysis and for storage. And so a lot of the companies that provide these devices have effectively AF detection algorithms within their software, which then marks up recordings that have irregular rhythms, and then it is up to the healthcare professional to then check those recordings and decide whether it's truly atrial fibrillation or ectopics or something else, or atrial tachycardia, etc. And so it's about getting access to that cloud software, that sort of portal, looking at these ECG recordings, or speaking to a healthcare professional who is comfortable looking at those things. So generally the devices are pretty easy to use. It just depends where the data then gets stored and who looks at it.
Thank you very much. We've just had a follow-up comment to the question. So cardio mobile and mobile single lead.
Okay,
Um,
so Cardia Mobile works in a very similar way, so that they're all predominantly these handheld devices are doing lead one atrial fibrillation, lead one ECG strips. So you're only going to ever going to have one ECG to look at. I haven't personally used Cardia Mobile much, but I would think some of those devices on the kind of connected iPhone or iPad or whatever will then provide the ECG rhythm strip, and then it's just up to the health professional to have a look at it and say whether they think it's atrial fibrillation or not. Was that the specific question, kind of where they find the ECG, or was it about how to interpret it?
I'm not sure. I think it was more about how to interpret it. So thank you so much for answering that. If anyone has any further questions, please leave them in the chat. Or if you'd like to ask them later and I can forward them on, also happy to do that. I'd just like to thank Dr. Nadarajah for today's session. If you have any feedback, I've provided the link to the very brief questionnaire that we have for our webinars. It only takes about a minute to fill out. So if you're able to, that would be lovely, as it really helps us to inform future webinars as well. I'd just like to say thanks again. And we hope to see everyone back soon for another webinar. So thank you.